Good evening, everyone. Thank you for joining. So, we are going to spend the next 1 hour on a disease that quietly sits in our clinic and yet it can still walk undiagnosed every single day, and that's glaucoma. Let's begin with two simple questions that does come in our mind or we do reflect upon is how many of our glaucoma patients are we missing every single day just because we think it's a routine on a busy day? And when we label somebody as glaucoma suspect, we are not always sure about what our next step should be. So, our webinar here is exactly built around these 2 points about how not to miss glaucoma in our clinic and how to approach a glaucoma suspect in a more logical, in a structured way. To begin our webinar, I would like to invite Dr. Murali Ariga, sir. He's a distinguished ophthalmologist based in Chennai, specializing in glaucoma, in and premium intraocular. He currently serves as a senior consultant with Dr. Agarwal's Eye Hospital, and he's had many key leadership roles. The former head of Department of Ophthalmology in Swindon Medical Foundation. He's been the editor-in-chief for the GSI, the chairperson for the Medical Legal Committee in the TNOA. He's also authored almost 44 peer-reviewed publications and 10 book chapters. He's been the editor of various journals. He's also received the TNOA, Dr. J. Agarwal's Excellence in Teaching Award in 2024, and has actively involved in glaucoma education programs and public awareness nationwide. Sir, please go ahead and we can start our webinar with the first topic, that would be how not to miss glaucoma in our daily practice.
Thank you, Dr. Sneha, for the kind introduction. And I think it's a very important and relevant topic and webinar with regards to not to miss glaucoma in the clinic. All of us are guilty of missing glaucoma in the clinic. All of us are guilty of, sort of not knowing how to manage our suspect glaucoma in our practice and so on. I hope that we'll be able to discuss and sort out some of these issues today. The few startling facts about glaucoma, I'll start with this, that glaucoma burden in India is huge. We have a large number of patients with cases with glaucoma. The prevalence is increasing in the sense that the aging population is increasing. So therefore, you're going to be seeing more glaucoma in the years to come. And in several of the glaucoma surveys conducted in South and elsewhere in the country and even worldwide, 93% of glaucoma, primary open-eye glaucoma in the country has not been previously diagnosed. So it's a large, literally a tip of the iceberg phenomenon. What we're seeing is only the tip of the iceberg. Many of those diagnosed with glaucoma actually in these surveys have been seen by an ophthalmologist in the near past, which means that many of them have missed the glaucoma on these patients. And 1/5 of those with glaucoma had blindness in one or both eyes, which means it's a blinding disease, slow, silent, irreversible blinding disease. And we're missing the glaucoma, and people are going blind as well, and it's not reversible, obviously. And the other startling fact about glaucoma was that 40% of cases of open angle closure glaucoma, pardon my mistake, but 40% of angle closure glaucomas were being treated as open angle glaucoma because gonioscopy was not performed. Simply assuming that every glaucoma was open angle, not doing a gonioscopy and not doing a YAG-PA to start with was another problem. So why are we then missing glaucoma in our practices? Obviously, we know some of the answers. It's a very silent, asymptomatic in its early stages, and therefore patients don't have symptoms. We don't have any single diagnostic parameter or test for screening. Intraocular pressure obviously does not rule out glaucoma. A single IOP reading, of course, will be misleading, and therefore we miss glaucoma if you go only by intraocular pressure as a diagnostic or a parameter to diagnose glaucoma. And we are missing out important glaucomatous changes in the optic disc. We don't really look at it very carefully and miss out the subtle signs of changes in the disc in glaucoma. Visual field limitations are there in very early stages, and you will know that visual field will be normal, even up to mild to moderate glaucoma. Sometimes visual fields are normal. And even the OCT imaging is not foolproof and will not give us a conclusive evidence that this is glaucoma. So a comprehensive eye exam is what will actually help us in the picking up the diagnosis of glaucoma. By not performing a comprehensive eye exam, why are we not doing that? Because sometimes with the time pressure, we're not able to do a comprehensive eye test, large volume OPDs, and we all have administrative burdens. So these are some of the reasons due to which we are not doing a comprehensive eye exam and missing the glaucoma. So how do we tackle the problem? The first and foremost is what we call as opportunistic screening. Everybody who walks into the clinic for whatever reason, presbyopia, refractive errors, any adult patient who walks into the clinic must have a complete eye exam, including the screening for glaucoma. And this could be a multimodal approach in a simple history questionnaire and checking for intraocular pressure, keeping in mind that corneal thickness is important in those with ocular hypertension. Also, keeping in mind that one single measurement of the pressure is not enough. So, take care of possible day variations and fluctuations in the pressure. Gonioscopy for every patient whom you can think of. There should be no threshold for doing gonioscopy in any given patient. A careful eye nerve, optic nerve head evaluation, looking for the subtle signs and, of course, the established signs of glaucoma. I'll come to that in a next few slides. And considering visual field and imaging in appropriate patients where we really need to confirm and carry forward the diagnosis and watching for the change and progression in glaucoma. All of these presbyopes who walk in should have a thorough test for not just vision and intraocular pressure. They should have a gonioscopy if possible and looking at the optic nerve in detail, searching for the glaucoma, especially those who are at risk. Those who are at risk, by this I mean first degree relatives, siblings with glaucoma, the very high myopes, the very high hypermetropes, the very shallow AC. All diabetics should be search for neovascularization. Don't miss the subtle early signs of NVI, which can actually progress on to secondary angle closure and so on. People with sleep apnea, people with ocular trauma in the past of any kind, several decades ago, they will all end up with maybe angle recession and related increase in eye pressure. Steroids in any form and any route, intraocular, topical, intravitreal, must be skin creams, inhalational, oral. Any steroid in any kind is a risk factor for raising the intraocular pressure. So all this has to be kept in mind, and the antenna must be up with regards to searching for glaucoma in these kind of patients. And I think I don't have to take a class to the audience about every diabetic. Make sure you document and write down as no NVI. That is, you look for NVI. Look for subtle signs of pseudo exfoliation, which may not be as obvious as in this picture. Telltale signs of old trauma in the form of sphincter ruptures, so traumatic mydriasis, the glaucoma flecken, the iris atrophy of angle closure glaucomas. Make sure you keep looking for them and don't miss them. A careful slit lamp examination of the front of the eye will give you a lot of clues as to the possible type of glaucoma and is there a glaucoma or not. So, what are the red flags that should raise suspicion in a clinic when you're seeing a patient? Intraocular pressure, obviously more than 21 in any adult, should undergo further testing like corneal thickness, angle, and looking at the disc and other aspects of glaucoma screening. Anybody with a disc suspect, maybe enlarged cup disc ratio, CD asymmetry between the two eyes, and anybody with a pressure of more than 18 with a disc suspect, an asymmetry in intraocular pressure between the eyes, more than say 3-4 millimeters of mercury, very large fluctuations in IOP, more than say 5 or 6 mm of Hg. A very thin cornea is also a risk factor, which should raise suspicion about possibility of glaucoma. A very shallow AC on slit lamp examination, like the picture you see here, should indicate that you should do a gonioscopy for sure. And like I mentioned, the optic nerve is going to be the key for the diagnosis of glaucoma. Asymmetric cupping, a cupping of, suppose the optic disc size is of equal size in both eyes, asymmetric cupping of more than 0.2 between the eyes, a violation of the isn't rule, neuroretinal rim thinning. I'll come to some of the disc evaluation parameters in the next few slides. Intraocular pressure, word about that. The Goldman applanation tonometer is the gold standard, and the NCT can be used in busy clinics for screening for intraocular pressure. I think Shiatz is no longer the practice for most of our clinics. It's not used in most of the glaucoma clinics. It's either the applanation and NCT for screening. Keep in mind that the corneal thickness is an important factor. If you have thick corneas, you have thin corneas, you have the average corneas. There is no real accurate nomogram for classifying and correcting the intraocular pressure, mind you. So you classify anything less than say 520 as thin, 520 to 540 would be average, and thick would be 540, 560 or more. Thicker corneas, you can sort of maybe every 20, 25 microns of thickness would be approximately 1 millimeter of mercury and so on. Keep the thickness factor, particularly if you're dealing with ocular hypertension. Don't overdiagnose and don't overtreat ocular hypertension. And similarly, don't miss out the ones with thin corneas and underestimate the intraocular pressure. With regards to AC depth assessment for angle closure, the Van Eyck test for the slit lamp, in which you look at the temporal slit for the antechamber depth, has a good specificity. In the sense that once you pick up something as a shallow AC, you must do a gonioscopy. And if you have what we call as a normal depth anterior chamber, that does not mean that you should not do a gonioscopy. So Manner test gives you an idea or an estimate of the angle, what is happening inside the eye. And definitely, if you have a shallow AC as picked up on a Van Herring test, you must go ahead and do a gonioscopy. Mind you, this test is not a substitute for gonioscopy. There's so many things which you can pick up on a gonioscopy, like the indentation will show you how much of apposition, how much of cynical closure, how much of pars is there any abnormality like a new vessel in the angle, is there any telltale sign of previous injuries like angle recession and so on. So gonioscopy is a key element, like I mentioned in the beginning, that people would miss trauma, people would miss telltale signs of old trauma and angle recession if we did not do a gonioscopy. With regards to choice of a four mirror versus single mirror and the choice of a gonio lens, I think everybody is very clear that we do need a four mirror lens, any kind of four mirror, Sussman, Posner, size type of lens with and without handle, because these lenses are flatter than the radius of curvature of the cornea. So therefore, you can actually indent on the cornea, and indentation would actually tell you what is actually happening with regards to cynical or oppositional closure and so on. Indentation gonioscopy is the key for diagnosing angle closure, spectrum of angle closure disease. If you are viewing the angle with a gonioscope and the posterior trabeculum meshwork is visible in more than half the angle, 180 degrees or more. So yes, if you have a PTM visible 180 degrees or more, it's possibly an open angle. But if you don't see the PTM in half the angle and you have to indent, suppose you indent and you find sine K, then you can actually record it as a primary angle closure. But if you don't have sine K on indentation, is the IOP raised? If the IOP is raised, yes, you can call it PSC or PSCS, depending on whether the IOP is raised or not. A very simple classification of the grading of angle closure spectrum based on the key element would be gonioscopy, the key element would be indentation, looking for signs of angle closure. So it's a very important step. If it's going to be a PSCS, you can decide on whether to do an angle closure YAG laser PA or not. If it's a PSC, you would treat to the YAG PA. PSCG, you would definitely start with the YAG PA. Some of the recent advances in angle closure disease management include the ASOCT versus the UBM. You will know that the UBM can actually see structures behind the iris root. You can actually look at the insertion of the ciliary body, the iris on the ciliary body, and the relationship behind the iris. Whereas with the ASOCT, you cannot see behind the iris. So therefore, a UBM is far more useful in conditions such as the plateau iris syndrome, and so on. Whereas the ASOCT is less useful in glaucoma. Newer parameters such as the lens vault, the relative lens vault, and the lens thickness, which we now get with biometry, is also quite useful in helping us in the management of angle closure glaucoma in particular. Like the line drawn between the scleral spur and how much the lens vaults in front of it, the relative lens vault can sometimes indicate that the lens is the culprit in many of these angle closure disease spectrum. So these are all the newer toys and advances we have. But mind you, the gonioscopy cannot be replaced by any of these tests. You do really need a simple clinical gonioscopy. Coming to the optic disc evaluation, which is the key element in glaucoma diagnosis. If I ask you a simple question as to give me one single parameter for glaucoma diagnosis among intraocular pressure, visual fields, let us say OCT, and even the disc photographs or disc evaluation, you can clearly say the predictive value in glaucoma diagnosis, the highest would be for the disc evaluation. You cannot diagnose glaucoma without having a disc evaluation, without having typical changes in the optic nerve. So the optic disc and optic nerve head is the key for the diagnosis of glaucoma. But we do have problems in the optic disc assessment for glaucoma diagnosis. What are these problems? The main problem being there is a large inter-individual variability between one optic disc and the other. So not all of them look the same. And there's a lot of overlap between glaucoma and normal. So very difficult to distinguish sometimes what is normal and what is glaucoma. So that is why the problem comes with the optic disc assessment. It is not exactly the same in all patients. So the optic disc assessment for glaucoma has to keep in mind the optic disc size and the shape, the neural rim, the width of the neural rim, the color, contour, and the vascular changes related to changes in the neural rim, the visibility of the nerve fiber layer, the cup to disc ratio, particularly the vertical cup to disc ratio, presence or absence of optic disc hemorrhages, and the peripapillary chorioretinal atrophy. Keep all of this in mind when you're evaluating the optic nerve head. And the optic disc size is a very important parameter to determine the cup to disc ratio as well. Suppose you have a small size disc, let us say a disc size of less than 1.6 millimeters like this, you will have a small cup to disc ratio, the vertical cup to disc ratio, and you will tend to miss subtle early signs of glaucoma in a small disc. Whereas if you have a large disc of, let's say, more than 2.2 millimeters, you tend to overdiagnose glaucoma. Cup to disc ratio is more than zero point 0.7. Therefore, you immediately say glaucoma suspect. We all overdiagnose glaucoma on the large disc. So learn to look at the disc size, estimate the disc size using some measurement of the optic disc size, either using a correction factor for the length which you are using for optic disc size measurements. And also keep in mind that the vertical cup to disc ratio is a measure and relates to the optic disc size. Without an estimate of the optic disc size, do not go by simply to the cup to disc ratio and then say this is glaucoma, this is not glaucoma, purely based on the cup to disc ratio. Because most of us somehow have been taught and oriented to looking only at the vertical cup to disc ratio. All the other parameters seem to be forgotten. So another way of looking at the optic disc size for those of you who use, let us say, a direct ophthalmoscope, the Welch-Allyn kind of 5-degree small aperture of the direct ophthalmoscope, a normal size disc would fall into the small aperture of a direct ophthalmoscope. A small disc would lie well within that, whereas a large disc would go beyond the size of the 5-degree of the direct ophthalmoscope. This is a rough estimate of the size of the optic disc. The neural rim generally obeys the isn't rule and is evenly distributed all along. And the isn't rule, by and large, holds good for almost all of normal optic nerve heads. And look at the striations of the nerve fiber layer. This is a healthy young patient with, you see the striations which you can see very clearly. So look for the striations. Look for the neural rim. See if the isn't rule is obeyed. Look at the striations of the nerve fiber layer, RNFL striations, and make sure that you don't miss the signs of RNFL defects like this. They're very fine, subtle defects sometimes. You will miss them unless you are really looking for them. So if you look at this disc is crying for help, looking at the number of RNFL defects that you have on the optic nerve head. These RNFL defects are generally seen within two disc diameters of the disc. They can be wedge-like, and the slit defects are wider than the retinal vessels. There are dark bands extending from the disc. Generalized thinning will be there with loss of brightness and density of striations. A red-free evaluation, red-free light evaluation, will actually pick up these kind of loss of striations, both diffuse as well as the wedge defects. And red-free is very, very useful in picking up the wedge defect. If you look at this carefully, you see a dark area here showing a loss of nerve fiber layer, and there's a very small notch here. And this actually, the red-free is clearly showing and delineating the wedge defect. So keep looking for these. A notch in the rim here, along with an RNFL defect, a notch in the rim with the vessel also showing you clearly where the neural rim losses occur. Don't miss these notches. And of course, you see the enlarged cup to disc ratio as well. You see the loss of the rim and the notch in the rim. So these are all the signs that you should not be missing. Bearing of the circumlinear vessel essentially is a vessel that lies on the neural rim in at least about 50% of eyes. And a bearing of this vessel, like you can see in the schematic here, actually means a surrogate measure of loss of neural rim tissue. When you're losing neural rim tissue in a given nerve of a patient, you will find the vessel is getting bad. It's nothing but a sign of neural rim loss. And so bearing of the circumlinear vessel indicates glaucoma disc change. A parapapillary or peripapillary atrophy of both the alpha and the beta zone is much more important. The large choroidal vessels become obvious and much more common in the glaucomatous eye. So look for beta zone parapapillary atrophy in an eye in which possible progression. It was not there some years ago. Now you start to see peripapillary atrophy. It could be a sign that glaucoma is worsening. And this is the beta zone. The width of the beta zone inversely correlates to the rim width at the same area. And a larger beta zone means a thinner neural rim, and therefore you are probably looking at the beginning of progression in glaucoma. Look for a disc hemorrhage. Disc hemorrhage is sometimes very obvious when you see it clinically, but more often you will find that you need to be looking carefully for them. You see these pictures here, a very subtle small hemorrhage here, a very, very small hemorrhage here, and a hemorrhage is almost merging with the vein here. You will tend to miss these, and these are all very subtle. You have to be carefully looking for them. Take pictures, and you'll find that a few months later, this disc hemorrhage may go away, but this can indicate that the glaucoma is getting worse in this patient. How does the cupping progress in these patients? a notch in the rim which will get localized, a polar notch, a bipolar notch, and a diffuse loss. All of them are possible. But what is most important is maybe look at the change over time. You take a picture today, you take a picture maybe serially after several years, you will find the RNFL loss is, the width is widened here. You see the vessel change here, the arrow showing you the change in the vessel as compared to previous findings. So this clearly indicates that the local RNFL defect has widened and enlarged. So serial photography, serial documentation, maybe if you're very careful, meticulous notes will also help you document that the optic nerve changes are worsening. The RNFL defect here, a notch in the rim, will correlate clinically with the visual field as well. And suppose you miss this on the disc, you can, when you have a visual field defect like this, go back and see the optic nerve picture, optic nerve head picture, the photograph, you will see the finding is there. It has to correlate. Glaucoma in the initial stages is asymptomatic. We all know this spectrum of being undetectable disease initially, going into changes, and then finally start seeing it on perimetry and then going on to blindness. So why I'm talking about that here is that you will find in the early stages, early glaucoma, almost completely everything will be normal, including the visual fields. As the glaucoma starts to show up, there may be a disc hemorrhage, there may be a small RNFL loss, but still your field will be normal. You start to see an RNFL defect, a notch in the rim, and maybe up to 20-30% loss of structure may be there. Still, you don't see it on perimetry, but you start to see it only when the structural loss is severe. So mind you that the early stages visual fields will not pick up glaucoma. You will probably see it on the structure like you see in these examples here, that a structural change usually precedes functional change in most glaucoma patients. It is not a 100% rule, but most of the time structural defects will usually precede the functional defects. The reason are so many reasons have been given for why functional defects don't show up early. One of the reasons could be that the HFA's test pattern of 24-2, 6 degrees apart, actually is a poor sampling of the nasal optic nerve head, and 50% of RGC is in the central 20 degrees, but we don't have too many test points with the HFA in the central 24 degrees, which is why we're actually not really seeing the field defects, even though there are structural defects. When a 24-2 is normal and you have a structural defect as you see it here, you can actually do a 10-2. A 10-2 will clearly show up the field defect when a 24-2 does not show up. This is another indication for doing a 10-2. Among the OCTs, you will find the spectral OCT will probably show up the defects like this, and even mild defects will start to show up. Whereas the stratus OCTs, the time domain OCTs, will tend to miss even structural defects. So pre-perimetry glaucoma using imaging actually depend on what type of OCT you're actually using. So missed glaucoma is a quick recap of some of the things which I mentioned to you. Refractive surgery, people posted for LASIK and phakic IOLs. People undergoing cataract surgery, pre-existing glaucoma can be missed. People having penetrating keratoplasty can have pre-existing glaucoma. The complications related to cataract surgery and PK, patients may develop glaucoma as they get older. This is a patient who had a normal intraocular pressure, 6/6 vision. On a casual examination, the NTG was missed because this rim loss was missed, the disc hemorrhage was missed, and there's a corresponding field loss. A classic NTG was missed because the diagnosis went with only a normal intraocular pressure. This is an example of where you can miss the glaucoma. A LASIK pre-op patient almost was very keen on having a refractive procedure done. You see the classic disc changes, you see the notch, you see the loss of nerve fibrillae, you see the peripapillary change, and you see the loss in structure as well. This patient almost underwent a refractive surgery without having a proper glaucoma evaluation done. A 36-year-old male with a unilateral raised intraocular pressure, just a subtle sign of damage to the sphincter due to the old trauma. And you can see the angle recession is almost nearly 360 degrees with the angle. Intraocular pressure was only in one eye. So make sure that the intraocular pressure, unilateral raised intraocular pressure with this telltale sign of an injury here, you should do a gonioscopy and make sure you pick up the angle recession. A young lady who had a keratoplasty in the past and was lost for follow-up, and intraocular pressure was borderline at that time. The field was nearly normal 6 months ago. Suddenly she says she has blurred vision. Then you make out that the visual field has actually worsened to almost a very small constricted field. Intraocular pressure was very high. The IOP was missed completely. Elevated IOP was totally missed because the cornea was so clear, nobody even thought that IOP has to be estimated. So this was a missed glaucoma and a post-PK glaucoma. So a take-home message with regards to our clinic evaluation is always perform a complete eye exam, not just a vision IOP. An opportunistic screening is more meaningful than screening and camps in the population. Do check for risk factors of family history of glaucoma, use of steroids, the trauma to the eye, and always all diabetics should have an eye evaluation to make sure you're not missing neovascularization. Do a careful optic nerve evaluation. Master gonioscopy, very crucial to avoid a misdiagnosis of open angle glaucoma. Stay updated with the techniques which are appropriate, but understand the limitations of technology. And whenever there's something you cannot handle, do not hesitate to refer out cases which you cannot manage in your practice. And we are the largest network of eye practitioners in the world, I believe. So let us pledge not to miss glaucoma anywhere in our network practice today. Thank you all.
Thank you. Thank you, sir. It has been really very informative. And I think every point has been clearly explained by you. I think I'll go to the questions later on. Now, I would like to introduce Dr. Manish, sir. He's an esteemed ophthalmologist and glaucoma specialist. He's practicing in Mumbai. He's the founder of Foresight Eye Center and Glaucoma Clinic, which is a unit of Agarwal's Eye Hospital, and also a consultant at Leelavati Hospital. Dr. Manish impacts transcends clinical practice. He's been a faculty member at the Glaucoma Society of India. He's also been a treasurer for the same. He's a long-standing member of the scientific committee of BOA as well for the last 20 years. So Dr. Manisha's dedication to advancing glaucoma care and education distinguishes him as a leader in the field, earning him both professional admiration as well as patient trust. So Dr. Manisha, we can please go ahead with your presentation, which is how do we approach a glaucoma suspect in our practice, sir.
Thank you, Sneha, for that lovely introduction. I would say that Murali has covered up ground on which I have to build up. Proper and very thorough talk by Murali on how to evaluate a patient so that you don't miss glaucoma is very useful. After you have done all that Murali has suggested, it is very likely that you will have cases where you are not sure whether there is glaucoma or there is not. And this is the situation where you have a suspect. As we all know, glaucoma is described as a trilogy of raised pressure, changes on the optic disc, and visual field changes corresponding to the structural changes you see on the optic disc. Of course, the third point is often missed, and that is angle changes. So you see all these four things, and if everything is present, then you know this is a classical glaucoma. There is raised pressure, there are changes on the optic disc and corresponding changes on the visual field testing. And then you say you have a proper glaucoma diagnosis. But what if everything does not add up? What if everything is not going together? So then we are not sure whether there is glaucoma or not. And that is the situation where you have suspects. So do you say that when everything doesn't match up, you say there is no glaucoma and call the patient again? No, because glaucoma is a progressive disease and has irreversible visual field loss. It is our responsibility that even the patients in which we are not yet 100% sure that this is glaucoma, we have to look at them carefully. Some of them we may start treatment, some of them we will continue, and that's what I'm going to talk about. We'll continue observing them, because if it is glaucoma, early treatment is effective in avoiding blindness during the lifetime of the patient. So it is also important to start treating the patients early. Therefore, if you have a patient where all the three factors which I pointed out are not present, then we say that this is a glaucoma suspect. So what are the types of cases in which different situations where you will have suspects? You will have disc field suspects, where the changes are seen on the optic disc when you have done a dilated examination using the guidelines given by Dr. Murali, looked at the optic disc and nerve fiber layer carefully and found some defects, then done a visual field test and found that some of that may be normal also, as Murali pointed out, but you find something there. And those are disc and field suspects, but they don't have any raised pressure. Even after checking the pressure on applanation tonometry, correcting and looking at the corneal thickness, you don't find the IOP being raised at any time in the day. So the IOP is not raised. Then that is a disc and field suspect. Compared to that, you have patients in whom On examination, you have found the IOP to be above the 22 cutoff. That means that it is above the statistical range of normal. But you don't find changes on the optic disc and field, and these are patients you will label as ocular hypertensives. Also, you will have patients who have narrow angles. You have done a Van Herrick on the first instance, then done a gonioscopy, and seen that patients have narrow angle appositional closure to some extent, but don't have any other changes. And you are going to call them angle closure suspects, as Murali already pointed out in his talk. As he said right at the beginning in his talk, I would like to reiterate that a careful clinical examination, especially on the slit lamp, looking at these three photographs, you can see these are common secondary glaucomas which are missed, and very often patients are labeled as primary glaucomas and the whole treatment goes off track. So a careful evaluation, including visual field testing, a very careful slit lamp examination, and of course a dilated fundus evaluation with optic disc evaluation using the guidelines he said. Imaging has become a cornerstone of our clinical evaluation, and in my course of practice of the last almost 30 years, I have seen how imaging has developed, and now we are using it a lot. Gonioscopy, unfortunately, is very often missed and avoided by a lot of general ophthalmologists, and that is a big pitfall and can lead to serious misdiagnosis, as Murali pointed out. And other situations you have to do diurnal variations and tachymetry, which he has already pointed out. So here you have a patient whose IOP is above the statistical upper limit of 21. So you must know, first of all, before you start doing anything else, is that IOP recordings are a skill, and using the right technique and the right technology is very important. We are not going to trust the IOP readings. Once you may have used an air puff tonometer, but if you find pressures high, you have to reconfirm that with a Goldman applanation, and you should remember that it is affected by things like artificial pressure, astigmatism, and corneal thickness. And even patients who sometimes have a little tight eyelid or a proptotic eye or a bulging eye, and you tend to put your finger there and cause artificial external pressure, which leads to artificial elevation, and that is not a real elevation. So before you do anything else, these are the factors you should look at first. And after that, whether you are going to treat these patients or not is guided by a very good study, which is the ocular hypertension treatment study, and which identified risk factors and said that patients who have a thinner cornea, as Murali pointed out, between 520 and 540, he pointed out would be normal. The OHTS used 555, but I would stand by Murali's suggestion that any patient whose cornea is thinner than 520, you would definitely treat if their pressures are recorded above 21. And if the pressures are recorded above 30, whatever the corneal thickness, whenever you have pressures above 30, they are a risk not only for glaucoma, but also for vascular occlusions. And you would want to treat these patients to bring the pressure down. Vertical CD ratio is also a guide, and OHTS has mentioned this and PSD, but these are factors which will come into your disc evaluation. So if you find the pressures to be about 21, 22, but you find changes on the optic disc or on the visual field, they do not remain ocular hypertensives anymore and become classical glaucomas. So you would definitely treat them. However, we must remember that of these patients, a very small percentage of patients actually convert to glaucoma in the OHTS data. Only 10% of these patients actually converted to full-fledged glaucoma in 5 years. And those which progressed shows the earliest detectable change on visual field and disc, not to a level which would affect the visual function. So carefully observing ocular hypertensives is a good treatment strategy, and reserve the treatment with medicines only in the high risk cases as identified by the risk calculators based on the OHTS. Now, when you have a patient who has changes on his optic disc, as you have identified on your careful examination and done the visual field, but the IOP is normal, and you would obviously in such patients try to do a imaging test as well, usually the OCT, and you would get possible outcomes is that disc and the field changes on imaging correspond, but the IOP on diurnal fluctuation and even after consideration of the pachymetry is always normal, and this is the kind of patient you are going to say is a NTG or a normal tension glaucoma suspect. However, if you find that the disc is affected and imaging is also showing changes, but the fields are normal, as in a series that was shown by Murali, you would call this a pre-perimetric glaucoma, and that would be a pre-perimetric glaucoma suspect. And whether you are going to treat or not will be a separate discussion which you can have. But if you see only a field defect which is showing, but the disc evaluation is not showing a corresponding change, or imaging is showing something but you are not able to see on the optic disc, these patients you will definitely like to observe further, especially if the other factors like the angle and the IOP on diurnals and all are normal. Then you are going to observe these patients and you would resist from treating them, definitely. If any situation you see angle closure, as Murali pointed out, especially appositional angle closure more than 180 degrees, you are not going to keep this patient under observation alone, and you are going to immediately go in and do an iridotomy. Because even if you have the slightest changes on the optic disc or imaging showing something, or the field showing something, and if angle closure is a different disease, and as Murali pointed out, it can progress much more rapidly than standard open angle glaucoma. So this is a typical example of a patient in which you could see that there is definitely a little bit of notching and a nerve fiber layer defect and an inferior defect on the visual field test. And this is the kind of situation where you will say that, yes, I would like to consider this patient, because if you see the visual field testing, the field defect is quite large and the mean deviation is almost 9.5. And you would like to treat this patient because it could be approaching fixation where you are going to have immediately the quality of vision going to be affected. So even if this patient is not showing other things, and you would like to treat this patient because the visual field change is very close to fixation. In the case of normal tension glaucoma, where even after doing diurnals, you are not recording pressures above 22, but there are changes on the disc, corresponding visual field changes are there, angles are open, then you have to still look at other causes before you label this patient as a normal tension glaucoma. Because the same kind of changes can occur when a patient has had an episode of elevated IOP caused by something else, that is a secondary ocular hypertension, which could be caused by trauma, which could be caused by uveitis, which could be caused by a short use of steroids, especially if the patient has been a steroid responder. And in these situations, the disc might have got damaged and there would be changes, but subsequently, once the incriminating agent has been removed, the pressures have returned to normal, but the disc and field changes throughout lifetime are always going to be the same. So you have to look at other things, go into the history of the patient, and most important, see how deep the visual field changes are. And the decision to treat as an NTG would be based, in my case, I would definitely look the risk of worsening. If the patient is going to progress and the vision is going to be threatened, you would like to treat the patient even if you are not very sure. However, if the visual field changes are mild and not near fixation, I can afford to keep the patient under observation, because NTG, the normal tension glaucoma study, has shown that normal tension glaucoma in most cases do not progress very rapidly, and milder normal tension glaucomas can be kept under observation and not jump onto treatment. So, as I said earlier, usually treatment is indicated when changes are close to fixation and of an advanced nature. Very early changes may be just kept under observation. In the case of pre-perimetric glaucoma, the visual field is normal. Definitive changes on visual field and corresponding changes are seen on the optic disc and imaging at a later stage. So IOP, if it is elevated and you find that There are changes on the optic disc and imaging, but visual field is normal. I would still start the treatment because raised elevated pressure is the single most important risk factor in glaucoma and it has to be taken care of. However, if the patient is not showing elevated pressure or is showing borderline pressure, you can keep this patient under close observation and repeat tests and see if it is a progressive condition. If the changes are progressing on imaging and visual field changes are appearing, then the case is very important to start treatment. So elevated pressure above 25 definitely needs treatment. But if the patient is not elevated and the patient is an NTG suspect with no field changes, you can definitely keep it under observation. But at this point, I would like to point out that patients have to understand what you are doing, and whichever language and whichever way you can explain to the patient that keeping under observation is a very important part of treatment. And putting drops is the second important part of treatment, but the more important part in all glaucoma patients is observation. So I always tell my patients, because we had been taught when we were students 35 years ago, that our teachers used to tell the patient, you have this glaucoma and throughout your life you'll have to go on putting drops. That is not what I tell my patients today. What I tell my patients is that you have glaucoma or you are a glaucoma suspect and you are going to remain one for the rest of your life. You will have to keep visiting eye doctors wherever you are. Ideally, the same doctor and the same practice would be better, but if you are migrating, then you have to follow up with someone else. But you have to remember that you cannot stop observation in a scientific and clinically relevant way, whichever technology is applicable at that point in time. Then comes the importance of putting drops. So this is very important that we explain this to our patients. Coming to angle closure suspects, a large number of patients have some grade of appositional angle closure in clinical practice. If you sit in your clinic and see 100 patients and do a von Herrick, and all patients who have a suspicious von Herrick, you put in a gonioscope and start looking at their angles, you will find a large number of patients having some degree of appositional angle closure. Studies have shown that a vast majority of these patients do not ever develop glaucoma in their lifetime. So evidence-based guidelines on how to treat angle closure is based on the classification which Murali pointed out. So I'm just skipping this angle. Gonioscopy, as Murali pointed out, is essential for glaucoma evaluation, and many important points can be missed if you do not do gonioscopy. Anterior segment imaging is a very useful and a beautiful technology, but it cannot replace gonioscopy. As you can see, this is one example where if you do it carelessly, you would assume, like in the left side, that the patient has an angle which is closed. But if you just tilt the lens or make the patient look more carefully straight, you will see that it is a pseudo closure, and actually, sorry, it is a pseudo open, and you can see that by indentation, the angle is opening. That pigmentation which you are seeing on the left is just the pigmentation anterior to the Schwalbe's line. So doing indentation gonioscopy is extremely important in clinical practice, as Murali pointed out. And this is another patient where the lens is a little larger in size, but the angle is still open, because once you tilt it over the hill, you can see an open angle. Now, this is a clinical skill. I don't expect people to start being able to do this effectively right in the beginning, but it is a skill. Without indenting, turn the lens and see the angle over the hill, and it is still an open angle. So it may close later on, but right now it is open. So looking at the angle is very important. As Murali pointed out, just appositional closure less than 180 or 270 degrees is just a suspect. Appositional closure with raised pressure or evidence of cynical closure would be called an angle closure. And angle closure glaucoma is when there is appositional or cynical angle closure with disc and field changes or with elevated pressure. And all these patients who fall in the category of PAC or PACG definitely need iridotomies. PACS, you will do iridotomies when the angle closure is more than 270 or there is a higher risk because of family history and things like that. You have to maintain caution with the angle closure patient. As I pointed out earlier, risk of blindness and rapid progression is higher in angle closure than POAG. We do not have broad-based prospective trials to give us guidelines, and often your decision to treat is based on your own clinical impression. Therefore, to summarize, glaucoma suspects in most cases, observation is the key, but it has to be done in a scientific and consistent manner. So this is where I would like to stress that scientific and consistent manner means using the same imaging and perimetry, and using the perimetry devices which have got a good wide range of normative database with software which can evaluate for progression and which has to be validated. So that is very important, to use the proper devices to do your observation. When the glaucoma is confirmed by seeing progression in a repeatable manner, or previously normal parameter starts showing change, then you can confirm that it is glaucoma. Treatment is definitely indicated when risk of vision loss is high, in a one-eyed status, or a patient who has a bad family history, and of course a patient who doesn't have easy access to medical care. In those cases, considering that glaucoma is a potentially blinding condition, you may initiate treatment. So there is nothing black and white. In cases, it is a clinical judgment, and you have to be very circumspect, look at all the factors, and then take your decision. Thank you very much.
Thank you, Manisha sir, for such a wonderful session. Like you rightly said in that take-home message, it's very important. Like many a times we as glaucoma specialists are shown some fields, we are shown pressure is this much, pressure is 26, and do we get it down? So one must understand how customized the treatment is for every patient. We can't paint them with the same brush. We can't have the same target IOP. Few questions I would like to ask you all is that, like, Manisha, sir, would you treat on the basis of an NCT or an OCT? Because this is what is happening in our practice.
Very true. You're very right. So NCT and OCT. So definitely NCT is only a screening modality, and you cannot take that NCT reading as anything except that it is an indicator that this patient needs to be looked at more carefully. So moment I find anyone who has got a high pressure on NCT, I'm going to immediately take that patient up and do a applanation tension. Of course, all patients I look at their optic discs and grossly look at the anterior chamber depth with a von Herrick and do a gonioscopy. This is done for all patients, so that is not a specialty for me. Once I see all this, then comes the OCT. OCT alone, stand alone, is not a good tool to evaluate glaucoma. There are lots of false positives. So looking at OCT images and jumping at decisions of glaucoma is a very, very risky thing to do. So I would definitely not look at OCT images by itself. I would definitely use it along with the other data.
Yeah, thank you. Thanks a lot, sir. See what happens in our day-to-day practice. Like, we three, we are glaucoma specialists, and it might not be for the, in our general practice when we see, like most of the time, the patients are seen by the optometrist, then they are dilated. Many a times we see the patients dilated itself. So what are those key findings when we see the patient dilated that we should go back and ask for an undilated slit lamp examination? You see that the disc looks suspicious, so we take a dilated IOP. Then, what are those signs that tell us, okay, we need to do an undilated examination, we need to do a gonioscopy? So many a times patients come to us, they come directly dilated. If I think in our practice, in at least most of the practices, this is what happens. We don't see them undilated quite a few times. So any points, Murali, Ariga sir, you would like to comment on this, please?
Yeah, a dilated eye exam, actually what can happen is the intraocular pressure could be higher than before dilatation for various reasons. And also you're going to have difficulty in actually estimating the gonioscopy if you're going to be having a dilated. You cannot really do a dilated gonioscopy and get a clear picture. What we generally instruct our staff, optometrists, junior colleagues, associates is that some of the red flags with regards to dilating or not, should you dilate or not a given patient, is one, intraocular pressure. Second is the anterior chamber depth. So we can actually train some of our staff, colleagues, even optometrists to look at the anterior chamber depth on slit lamp. A torchlight examination actually is no good. You must teach them to look at the slit lamp, and if you suspect the anterior chamber depth is shallow, or family history of glaucoma or raised intraocular pressure, something like more than 19 or 20 or 21, do not dilate the patient. Have somebody, have a doctor, have a fellow, have an associate, see the patient on a slit lamp, and then take the decision to dilate. So once you dilate, you're done. You're wasted the patient's time. You have to call them back another day. So make sure the decision to dilate is taken carefully and not as a routine. Even if somebody comes in for a routine refraction, do not dilate as a routine. Suppose we have a shallow AC, narrow angle, family history of glaucoma. We have now the devices in which we can actually take a good non-mydriatic wide field picture and evaluate the fundus without really need to dilate. So we don't have to dilate unless it's absolutely necessary. And we need to have some red flags in your system, depending on what kind of system you're having. For example, in CMH, whoever comes to us will not be dilated until the glaucoma evaluation is done. I think in other practices, each one of us has different practice backgrounds. So maybe you can set up your own practice backgrounds in such a way and you red flag things in which you don't dilate routinely.
Yes, yes, very true, sir. Like in our practice also, it's most of the time it's torchlight examination, but then yes, most of the patients above 40, we do a Perkins by a trained person, or most of them are subjected to an applanation tonometer and an undilated slit lamp examination. So, but in general practice, sometimes it does get difficult. So we need to pick up those red flags. Another question is, how often should one do a gonioscopy in a previous diagnosed open angle glaucoma patient?
Yeah, I think there's no harm. Generally, what we practice is that at least the documented annual gonioscopy is useful. At least once a year when the
Yeah.
patient comes back for a follow-up. Suppose something has changed. You've done a YAC PI or you've done an SLT or you've done some intervention or some cataract surgery. Patient has developed diabetes, some laser has been done, for any other reason, intravitreal injection has been given, or patient has undergone a cataract surgery also. If something has changed in the patient's ocular ophthalmic history, don't hesitate to do a gonioscopy again. The threshold for doing a gonioscopy should be very minimum. Like we will literally keep this gonioscope at the slit lamp, and there should be no reason to hesitate to take it out and stick it in the patient's eye. One of my teachers, Professor Ravi Thomas, used to say that the only contraindication for a gonioscopy is when the patient doesn't have an eye and the surgeon doesn't have a hand. Otherwise, you do gonioscopy for all. So there's no really need. There's nothing like an
Yes.
indication for gonioscopy. And the more you do the visual science, you keep doing
Yeah.
it, then you realize that you've reached a point in which you're really adept at gonioscopy. So gonioscopy should be done by all. And at least one take-home clear message which we can give everybody today is that learn gonioscopy, do it for everyone, and do it for all your colleagues and all your staff in the hospital, so you get a good practice to how to stick the gonioscope into a patient's eye.
Yeah, very true, sir. I think we miss most of the times we miss because one is we are not looking for glaucoma. If you're looking for glaucoma, most of the time we will get glaucoma. We do see that somehow some telltale signs are there. And second thing is our clinical skills. I think we need to train and we need to educate more and more, and we need to practice. It's just these basic skills like gonioscopy, applanation tonometry that we work on. I think that can really help us pick and treat glaucoma. Another question to you, Manisha sir, is that when we say glaucoma suspect, okay, that's the time when we have to advise a few scans. Now, what happens in clinical practice is those scans, there are certain logistics, they're expensive. Patient has come to you and they will be like, I didn't have a problem. I came for a routine eye checkup. Okay. And then we are subjecting them to multiple scans. This is what happens, especially in our private practice. What we see is, okay, a battery of tests. So would you pick a single test and then decide, or do you have preference for any tests? Are there any indicators as to how many tests should be done? Because we know we have to do the gonioscopy, the PACI, the perimetry, OCT. Any sequence of tests, or do you just advise all of them, Manisha sir?
So basically, see, gonioscopy is not charged separately. It's a part of your clinical evaluation. So that gonioscopy you can remove from your list.
Yeah.
Definitely, there is an extra charge for doing the visual fields, OCT, pachymetry, definitely, and a disc photograph. So what we have done is we call it a package.
Yes.
We tell the patient that all these tests are done as a part of the package, and sometimes they say that no, we don't have the time for visual field today. We have this kind of patients, so we tell them, okay, the package will remain the same. You come tomorrow, day after, and do your visual field separately. That's okay, but it is still a part of the package. Now, the question that arises is, do I do separately? Means, do I do only a visual field and not do an imaging? Well, there are
Yes.
patients where, I feel that imaging is quite useless. You can see on the optic disc, that the nerve is already cupped out almost 0.99, and there is hardly any rim visible. These are not the patients in whom imaging is going to add anything. And so I would definitely cut imaging out. Also, patients who have got a very large amount of peripapillary atrophy, tilted discs, and very often there also imaging is not going to add any data to me. These cases I omit out the imaging, and it is removed from the package, and a discount is given to the patient. So sometimes we do cut out this. Now, regarding visual fields, now that is the question, is that visual fields I am very reluctant to cut out of, because visual fields actually gives us an idea about how much the glaucoma is impacting the vision quality of the patient. So I am not very happy to remove visual fields from the list of testing usually, unless very rare situations where your patient is mentally retarded or patient is not able to sit at all. And these kind of cases, sometimes very rare cases where we say, okay, we'll do a OCT alone, and OCT and fundus picture, and not do a visual field test. So that is not very commonly done. As far as pachymetry and all, I am not charging separately for pachymetry. It's all part of the package. So it is done partly quite automatic.
Okay. I mean, because in our practice, we do come across these things. So that's the reason. Thank you. Thanks a lot, sir. So there are a few questions in our chat box we would like to address. Murali, Ariga, sir, this one, if you could please help us with this. Suppose a patient is instilling anti-glaucoma medications for a PACG before cataract surgery, and after cataract surgery you see that the angles have opened up. What will be the further management? Do we have to continue the anti-glaucoma medications, or do we stop?
See, the immediate post-operative period after any intraocular surgery, generally we tend to avoid a prostaglandin post-operatively, at least for the first few weeks. If at all you really need to prescribe, say, glaucoma medication or anti-glaucoma medication, post-operative for controlling IOP, you'd probably stick to drugs like brimonidine, dorzolamide, timolol. You'd avoid prostaglandin as far as possible. And do not give too many drugs in the post-operative period. Stick to a combination, either timolol, brimonidine, timolol, or dorzolamide, timolol, something like that, depending on the need and contraindication or how the patient tolerates and allergies and so on. We'd avoid prostaglandin for sure in the immediate post-op. But we don't stop prostaglandins immediate pre-operatively because of so many constraints. We have stopped the practice of not looking at prostaglandins. We continue prostaglandins even up to the previous day and operate tomorrow, and thereafter stop the prostaglandin immediate post-op.
Okay.
Actually, I would like to strongly differ with Murali. I don't stop prostaglandins for anyone. And I continue, and I've been doing that for the last 25 years. And I will say my personal experience does not support stopping prostaglandins unless the surgery goes, during the surgery, you face an posterior capsular rupture, or in the immediate post-operative phase, suddenly you find a lot of inflammation. These are extremely rare situations, and in those cases, definitely. But as a routine, I don't stop prostaglandins for any cataract surgery, post-operative as well. But the question that that person has asked is not fully answered. So I would like to go a little further, that if the angle has opened after your cataract surgery, that is a good thing. But your decision on anti-glaucoma medicines will be based on the intraocular pressure. So you are going to observe the intraocular pressure. Second thing is that definitely in the first few, maybe a week or so, or 15 days post-operative, you do expect sometimes IOP spikes. So even if I say, supposing the pre-surgery intraocular pressure was say 15, 16, and post-surgery I find intraocular pressure has dropped to 12, that is a significant amount of drop, I will still not stop reduce the anti-glaucoma medications for the first 15 days. After that, if I consistently see that the pressure is low, then I'll definitely start trimming the medication. So if the patient is on 2 or 3 drugs, I'll start reducing one by one and see what is the impact on intraocular pressure. So the decision on reducing intraocular pressure in a patient who has undergone cataract surgery with angle closure will be based on your intraocular pressure and not just on your angle reopening. So that is the basic message.
And to add to it further, it is PACG. So when you're telling me it's PACG, that means there is nerve damage that you must have seen pre-operatively. So I think at least what we do is that we wait for 1 month, continue with all the pre-op medications going on because there may be some amount of steroid response as well. And after 1 month, subject the patient to your glaucoma test, you look at the central corneal thickness, so on and so forth. And then I think after a month, I start titrating. But if it is PACG, that means you need to monitor the disc also as well and have some target IOP set.
I'm actually wondering, suppose you have an established PACG and you're doing a cataract surgery and your glaucoma is, let us say, moderate to severe. I think just doing a cataract alone from moderate to severe glaucoma, the cataract alone is not going to be enough. I think most often nowadays we would combine with the MIGS mixed procedure, and we do traps less and less unless it's a very severe glaucoma. So most of the time the mixed procedures do very well for even mild to moderate PACG as well. So as a routine, we now do a phaco with an MIGS procedure, especially with the mild to moderate. And for the very severe glaucomas, you could think of maybe a trap. So leaving the glaucoma unaddressed when you're doing just a cataract alone would end up with some of the medication problems and then the relates to compliance and those issues post-operatively as well. So I think you really need to take a decision on, are you doing a cataract surgery alone or are you doing a combined cataract MIGS kind of procedure for depending on the severity of the glaucoma. Basically, it depends on the glaucoma severity rather than the cataract type of cataract surgery.
Okay. Sir, if I may also ask or maybe add to it, is that when you say you have a angle closure, and I think your mixed procedure would even depend upon the amount of synechial closure. That's very,
Absolutely.
very important because I think
Absolutely. I find that my mixed
understand
procedures do very well, particularly angle closures, do quite well with the minimum. If there's an extensive synechiolisis, you do a goniosynechiolisis, and then you also look at the meshwork as well, and the angle opens up significantly. And most mixed procedures do work well with and without goniosynechiolisis as well, especially the nasal angle to 100, 120 degrees and so on. I think we're getting away from the title of the webinar today.
Few more questions is a question about would we use anti-glaucoma medications, especially of the newer companies, because we don't know how efficacious that would be. I think this question is, I think if Manisha sir or Murali Ariga sir, would you all like to address this? Newer company products, are we like vis-a-vis your established company products that we've been using for years? There are newer companies who's coming with anti-glaucoma medications. How would we look at how efficacious they are? And should we
I think
give
you're actually again opening a Pandora's box here.
Yes.
So we do have this what we call as the established, the so-called innovator brands like standard brands like Xalatan, Travitan, and those kind of glaucoma medication, as compared to the generic brands we have from Cipla, Sun Pharma, and those kind of things, and the newer true generics which you have from the Jan Aushadhi kind of true generics. So the problem would be like, suppose cost is a serious issue. The government actually would like us to use generics and generic brands because the cost advantage is going to be there. But there have been issues with generics in the sense that a lot of efficacy issues with generics, true generics that is. Generic brands are also not without exception that you have problems with generic brands as well. So given a choice, I think I would stick to a innovator brand which I would trust. Maybe let us say I evaluated, let us say 5 or 10 brands. I would stick to them. I would not really go in for new brands whom I have no experience or I have not evaluated. But if somebody is switching to a brand or some other drug or some other company which I have not tried in the past, what I would advise them is a closer follow-up. Look at the efficacy. Suppose you're switching from one brand to other brand. Check the efficacy of the drug, check the intraocular pressure, and also monitor them more closely if they are switching. But I would generally not venture into companies or drugs with whom I have no prior experience. And I would stick to maybe 5 or 10 known brands and known devils rather than going and venturing into the unknown.
Okay. Thank you. Thanks a lot, sir. So just a few last questions more. How often do we need to start anti-glaucoma medications post or period after a mixed procedure? So, Manisha, sir, would you like to take this question, please?
Basically, after a mixed procedure, usually it is done with a cataract surgery. And then we observe, I check intraocular pressure every visit for these patients. And definitely we'll see when the pressure start going to a level where you are not very happy whether it is with us, because it could be also a steroid response. Quite often you see this with the patients getting a little bit of a steroid response. So you can start one of the medications. And once your steroids start tapering down and you see patients coming, pressures coming down, you can switch back. So
Okay.
usually the guidance to start the drops for intraocular pressure reduction would be based on the intraocular pressure itself.
For primary angle closure patients before a YAG PI, should we start anti-glaucoma medication? So should we wait till PI and check IOP and start the AGM? So I think this totally depends upon your baseline intraocular pressure, and then you need to get that down and do a PI. If the pressures not much significant disc damage, pressures in your mid 20s and all, you can do a YAG PI and then decide about the anti-glaucoma medications. For steroid responder patients, how long should we advise anti-glaucoma medications? Murali, Ariga, sir, would you like to please comment on this one, please?
Yeah, the basic problem here is the steroid. The sense that once you identify it's a steroid-induced glaucoma, steroid-induced IOP rise, you need to taper it off as quickly as possible. If possible, stop it if you can. If it's immediate one post-op, you can afford to switch to a say loteprednol, furomethalone, or you can switch to napafenac or NSAID kind of drops. You can take off the steroid if possible. Take off the steroid once the offending agent or the steroid is stopped. Generally, if the true steroid response, the IOP will start falling, and in the interim period, you could probably give some medication to control the intraocular pressure, either one or two drugs, topical, maybe a little bit of acetazolamide, short term. Usually, generally, it settles within a few weeks. Persistent, very high IOP following a steroid is uncommon. And that can happen, of course. If that happens, very occasionally you may end up doing a trabeculectomy even for an uncontrolled, non-responsive kind of a steroid-induced glaucoma, which is the exception rather than the rule. Generally, stopping the steroid, giving him some medication, in the short term, generally it settles in a few weeks.
Yeah. I think very few steroid responders, we need to manage them surgically, but yes, there are those few cases as well. So in a concentric cupping with early RNFLDs, how is cataract surgery planned? I think if the intraocular pressure is below 20s, I would say you can go ahead and do the surgery depending upon how your disc is, and then you can evaluate for glaucoma if the pressure is under control. I think anything else you all would like to add to this?
No, I think we all know in mild glaucomas, the cataract surgery itself lowers intraocular pressure
Yes.
to maybe 2 to 3 or 4 millimeters of mercury. So if you have a mild glaucoma in a patient who has cataract and you probably feel that he has well tolerant to medication, there is no need to subject them to an additional glaucoma procedure. You can just do the cataract alone for a mild glaucoma. Only when it's a moderate glaucoma, you feel patients cannot tolerate medications or have allergy to medication, then I would think of a mixed procedure in addition to the cataract.
I think we've done with most of the questions by our participants. So if we have, this is one last question I would like to take, is that if we have a patient who has cystoid macular edema, would we continue, and the patient is on prostaglandin analogs, would we continue it or would we stop it?
I would definitely stop it. I would
So
definitely stop it. It is a very clear indication of stopping the prostaglandin analogs if we already have CAV developing. So the
okay.
question that I would like to extend from this is that I have patients who who are on glaucoma treatment, developed a CRVO and have developed macular edema because of the CRVO. Now, are you going to stop the prostaglandin or not? This is a big confusion. You know that the cause of the edema is not the prostaglandin, but it is the vascular incident. But prostaglandins are associated with macular edema. And as you know, these patients with BRVO, CRVO, you give them intravitreals, the edema reduces, and then a little time it comes back. And you have to keep giving. And even in patients who are non-glaucomatous and non-prostaglandins, also the same thing happens. But when it happens in a patient non-prostaglandins, there is a debate between the glaucoma specialist and the retina specialist. And the retina specialist feels that prostaglandin is the cause. And I have had patients in whom I have withdrawn prostaglandins in that situation as well, and treated them, finished the whole treatment of the macular edema, given them almost 6 to 8 months when the macular edema did not recur, and then restarted the prostaglandins.
Yeah, I think I agree with Manish that there is no clear evidence that prostaglandin actually worsens or is a causation for severe macular edema in these kind of patients. But in the absence of evidence, in the absence of clear guidelines, and this kind of sort of division between people who think that it worsens and people who think it doesn't worsen, I think a general consensus, we can't really do trials and studies on these kind of patients. So general consensus, when you have an alternative, give an alternative and avoid the prostaglandin.
And I mean, just to add, because we're talking about the prostaglandins, would you all give it in patients who have herpetic keratitis? Or would you continue it in patients?
Definitely not. I think we have clear evidence that
Yes.
it worsens it. Stopping it in one particular series of case series as when they were re-challenged the same patients, it came back. So there's a clear evidence that it can worsen, it can reactivate. So I think a clear no when there is HSV keratitis.
I think it's been a wonderful session, sir. Thank you. Thank you, Dr. Manisha. Thank you, Dr. Murali Ariga. I think most of our questions have been answered. I think thank you, all the participants. It's been a really wonderful session, quite an interactive one as well. And I hope we practice what we've learned today in our practice. And yes, free feel to ask for any help. And we all are here. Thank you. Thanks a lot.
I think we must thank the Clinical Education Board led by Dr. Preethi and of course the team of Clinical Education Board, as well as yourself, Sneha, for moderating this so well.
Thank you.
Thank you, Sneha, and thank you all the members who helped in the back office, Mr. Sridhar and Preethi and all of you for organizing this. Thank you very much.
Thank you, the clinical board. Thank you for giving me this opportunity. It's been a wonderful session. Always great to learn. Yes, hope to see you all again. Thank you.